Dr. Alwbari. He will give us a talk about the targeting KRAS mutation in metastatic non-small cell lung cancer. Dr. Alwbari, thank you again.
Dr. Amerta, thank you very much. This is a marathon of me presenting. So let me try to share the screen again. All right. So thank you, Mervat, for the introduction. I'd also like to thank Amgen for giving me the opportunity to talk about, in my opinion, a very important and upcoming agent that we will use it certainly in our practice soon. So targeting KRAS mutation in non-small cell lung cancer. This talk is sponsored by Amgen. The talk is simply divided into an introduction, then we'll talk about KRAS, and then sotorasib, which is the agent that is being used in targeting KRAS. So 2.2 million cases of lung cancer worldwide, 1.8 deaths per year. Again, it tells the story that we still need to do a lot for lung cancer. Majority of lung cancer, obviously, are non-small cell lung cancer, 15% small cell type, and most of the lung cancer patients they present at advanced stage, and we actually are doing rather okay in terms of improving the survival of lung cancer. Still, we're behind. The distant metastasis overall survival is poor. But look at the yellow line here. You see that in the last 20 years, we doubled the survival for lung cancer patients, in part by using the target agent as well as the immune therapy. This is a 36 months survival in the KEYNOTE-189. You see 1.5% or a fold improvement in the survival for lung cancer, advanced lung cancer patients. When the guidelines recommend a broad multi-gene NGS testing, and I think in Saudi Arabia, most at least the big centers were doing that. KRAS is one of the points or one of the mutations that we test for. And when we break down of the non-small cell lung cancer, we see that 55% of them are adenocarcinoma. Excuse me. Now, 70% of the cases were able to identify a driver mutation, and in 31 cases, no oncogenic driver is identified. And there was an avalanche of small molecule treatment for targeted therapy for non-small cell lung cancer, some of which we have 3 lines of treatment in the case of EGFR and ALK positive. And we're also improving in the on the other targeted or oncogenic driver mutation. But when we come to KRAS, which is actually 25% of non-small cell lung cancer, there hasn't been any approved agent up until recently, or there hasn't been an effective agent to inhibit KRAS, rather than approved. And the KRAS is very common, not only in lung cancer, it's actually extremely common in pancreatic cancer as well as in colon cancer, among others. But specifically, the KRAS G12C, which happens in 13% of non-small cell lung cancer, has a particular interest because of the target that has been identified and introduced in the trials recently. So KRAS G12C is considered to be mutually exclusive, so it rarely happens or co-occurs with other EGFR or other driver mutations. So when you have KRAS G12C mutation, probably that's the driver, and you probably will not find any other driver. And it's a truncal mutation. That means that if you have it at diagnosis, from the primary site and there is a disease progression or metastasis, expect the KRAS to be positive there because it's a main mutation, it's a truncal mutation, and it's not subclonal mutation. And as all driver mutation, it happens in more in adenocarcinoma and more in non-smoker, but KRAS particularly can happen in in squam as well as in smokers. So we have to keep a broad prospect in terms of testing patients. And those who have historically who have KRAS mutation, KRAS G12C, do have poor outcomes in general. The progression-free survival is worse than those without KRAS mutation. And as all lung cancer, the more lines you go through, the less likely that you will benefit from these lines. Not only that, in KRAS specifically, the patients they do poorly with first line and they do poorly with second line. So you end up historically with 1 in 5 patients with KRAS G12C getting systemic treatment in the second line. So that's not very specific to KRAS because we know that the progression-free survival, for instance, this is a durvalumab trial in the concurrent chemoradiation. You look at the progression-free survival for patients with non-driver mutation, it's much better than the one with driver mutation. So the fact that you have a driver mutation makes the PD-L1 positivity sometimes irrelevant and makes the immune therapy less likely to work than if you have no driver mutation. As all EGFR receptors, the KRAS has an extracellular domain and intracellular domain, and most of the TKI work in the ATP binding pockets in the intracellular domain. What's unique about the KRAS G12C is it has a cysteine 12 that makes a potential covalent binding site and P2 pockets as well as H95 residue that basically makes the molecule that binds with these characteristics effectively in KRAS G12C. In other non-G12C, it does not have these characteristics, which makes it more difficult to target. Once you inhibit the KRAS, there's a significant downstream effect of inhibiting the signals that promotes the oncogenesis in the tumor. Currently, the guidelines, the NCCN guidelines points the KRAS testing to be maybe useful, but I will show you in the coming slide that actually we have a target for it. So it's now should be the standard of care testing. In fact, in Saudi Arabia, I know that we tested routinely for non-small cell lung cancer in almost all the cancer centers here in Saudi Arabia. Despite the recommendation from the guidelines and the 43% of the academic centers, they test the KRAS. It's not as common as EGFR and ALK, but we should do more and we should do better because we have a target agent now. Now, what if you don't have a tissue for diagnosis? The liquid biopsy is an option. It's a less sensitive, close to 70% sensitivity, 75%. But the specificity is high. So we always strive for a tissue biopsy, but liquid biopsy can be an option, especially if it's positive. Now, if it's negative, then you probably need to do a tissue biopsy. So let's talk about the agent sotorasib, which is the first in-class target therapy for KRAS G12C driven tumors. And as I mentioned earlier, that the characteristics of the cysteine 12, as well as P2 pocket and H95 residue, make the altogether make the sotorasib an effective agent that basically binds the KRAS in a very effective method. The binding is actually irreversible, so that makes the inhibition irreversible, and that inhibition occurs really early with small doses in the preclinical trials. We see that the half-life here is 20 to 24 hours in the cell lines, and that the sotorasib exhibited a highly selective binding to G12C because of the design of the molecule. So it really spares the off-target effects. So, and that was a problem when we use monoclonal antibody to target KRAS by cetuximab, for instance, in lung cancer. It produced so much problems because of the off-target effects, but not the case with sotorasib. It also, in the preclinical at cell line, it induced significant cell line death and viability, reduced significantly with mutant cells, while it spares the non-mutant, the troubles. Now, because of the design of the sotorasib, the occupancy of the KRAS was 100% in the cell lines, and that occupancy happened really early, in less than 2 hours, and it was sustained in cell lines for 2 days. So it's an effective treatment, it's a high affinity, and it works for very, very long time. And that's why we'll see why it's a single dose, daily dose that can produce that effect. So how about xenograft tumors? The results was significant in human tumor and xenograft models. But even in the immune competent mice, it produced not only effective, not only it was effective against the tumor, it produced a pro-inflammatory tumor microenvironment, which is very interesting. Similar idea of trastuzumab in breast cancer, where it actually enhanced the immune system. So it's an added benefit of sotorasib by reducing the signal transduction as well as enhancing the immune system to and disrupt the microenvironment to cause tumor demise. In preclinical trials also, it has been tried in combination with chemotherapy and MEK inhibitor, and it was it showed signals of improvements, as well as in PD-1 inhibitors in murine studies that really showed an effective, that obviously this is, we're talking about preclinical trials. How about the code break 100? This is a dose finding or dose limiting toxicity, as well as safety trials and the recommendation of phase 2 dose. So these patients with multiple tumors were enrolled in a dose escalation method, then dose expansion phase. And the primary endpoint obviously here is to find the appropriate dose for these patients. So what was interesting is about 70% of patients enrolled on the phase 1 trial were still receiving treatment on the data cutoff, and most patients on this trial are heavily pre-treated, received more than 4 lines of prior therapies and 3.5 lines, so roughly 4 lines for non-small cell lung cancer. So this is a 5th line treatment. Yet, a majority of patients who actually have received platinum doublet, and more than 90%, 97% received platinum doublet, and 91% received PD-1, PD-L1 therapy. So they have received all the effective treatment. In fact, some of these patients have received EGFR and TKI also for the rare cases where there is G12C and or ROS or EGFR mutations. So what happens is that the final dose that showed no significant, the most favorable side effects with no significant side effects as sotorasib 960 milligram dose daily. And 34% reported adverse event and were grade 1 and grade 2, and close to 8% actually had grade 3. Most of the side effects were GI, some skin toxicity, but the majority were GI. Minority of patients had LFTs elevation. So it really has a favorable safety. Remember that these patients, when you have patients who are treated for lung cancer in the 5th line, you expect these patients to do poorly. So there were fatalities in phase 1, 11.8% serious adverse event in 23.5% in non-small cell lung cancer group, but it's still, this is a 5th line treatment. So rather the data is impressive. And in the non-small cell lung cancer group, 35, similar to the all groups, so 35% grade 1 and 2 side effects, and 8.8% had adverse related events of grade 3. So because of the long half-life and because of what we have mentioned earlier, that the sotorasib 960 milligram single dose daily is considered to be the appropriate dose for phase 2 and 3 clinical trial. In fact, in the non-small cell lung cancer group, as far as disease control rate, which is one of the outcomes, it was 100% of the patient at dose of 960 showed their disease was controlled, and the overall response rate in lung cancer was 54%, and as I said, the DCR was 100%. And add the data at the cutoff time, 70% of the patients receiving 960 milligram will continue to have the treatment, which is, in my opinion, rather impressive as a 5th line treatment for non-small cell lung cancer. Now, this is not unique phenomena in non-small cell lung cancer, though we concentrated in it. In fact, the efficacy of sotorasib in G12C tumors was seen even in pancreatic cancers, melanoma, and GYN carcinomas. So the bottom line here is that KRAS G12C occurs in 13% of non-small cell lung cancer, and we should strive to test patients for it. Remember that if you have squamous cell or smokers patient, you still can test them for sotorasib for KRAS mutation. And it's been long considered as an undruggable up until the identification and discovery of this small molecule AMG 510, which is sotorasib. And it presented in the preclinical trial, the combination as well as the monotherapy showed encouraging data, and it has favorable side effects, though most of the side effects were GI, but they are not majority were grade 1 and 2. And in non-small cell lung cancer, the overall response rate in heavily pretreated patients, 54%, and disease control rate of 100% on the 960 milligram dose. Now, there is a 1B, phase 1B for break 101 that uses sotorasib with combination of multiple agents, including PD-L1 and MEK inhibitors. And there is a phase 3 that lots of our centers here in Saudi Arabia are participating in, a second-line treatment of sotorasib versus docetaxel in non-small cell lung cancer after progression on the first line. This is a breakdown of the trials that are ongoing or recruiting. And with that, I would like to thank you very much. Thank Dr. Mirbat and Amgen, as well as the organizers, for giving me the opportunity to talk about that.
Thank you very much, Dr. Alwbari, for excellent presentation and doing 2 presentations down the road.